thoracic region, especially at the level of T5, T4, T5, in the lower thoracic region, and even in the lumbar region. But at each of these levels, we're talking different muscles, we're talking different ligaments, we're talking different anatomy. And so, well, what can be asked is actually, is erector spinae plane block a universal remedy, whether it be for thoracic surgery, abdominal surgery, spine surgery, even proximal limb surgery, whether it be upper or lower limb? There have been studies that have studied the erector spinae plane block. So when we look at one regional anesthesia technique and see that it's so diverse in terms of indications, well, we tend to see it as a panacea. But as we all know, panaceas don't always very well work. So on this anatomical drawing that I made, you can find the intercostal space, but with a little bit more detail than what I showed you previously from the first paper describing this. If we isolate the spinal nerve at an intercostal level, well, we find that in the posterior part of the screen, right there, we will find the posterior branch of the intercostal nerve. And then we find the lateral branch, laterally of course, and the anterior branch. And what is also compelling is the fact that these nerves, these spinal nerves, communicate with the sympathetic trunk, right? This is the autonomous part of your body, one of the two components of that autonomous part. And that sympathetic trunk that you will find right there on the right side of the slide, well, communicates with the spinal nerve through two rami communicants, the white and the gray ramus. And so there is information traveling from the somatic nervous system towards the autonomic nervous system and vice versa. So this is also something important, because if we look at what we want to achieve, for instance, for abdominal surgery, we want to achieve a proper block of the abdominal wall, but we also want to block nerves that are going to the viscera, that innervates the viscera, especially because the pain sensation, it travels with the sympathetic nervous system in that region. But we'll talk about that in a later course. If we look now at what happens in terms of really what happens in terms of anatomy, well, this is cross-section that we made at our lab. And so what we see in that cross-section is that there is a spinal nerve emerging at the intervertebral foramen, and you can see also there is a spinal ganglion, and from the ganglion there is one root. We cannot see really the anterior part of the spinal nerve, but we, however, see very well those two branches already divided that are making up the posterior ramus, right? And here you would find the spinal nerve with what is pinned down in that region being the sympathetic trunk. But that's a dissected cross-section. If we look at what we usually see, well, this is what we see. Everything is joined together. There is no negative space in the human body. Everything is occupied, right? Well, on the left side of the slide, you can see that I tried to show you what the paravertebral space is. But our region of interest today is more than that, well, or less than that, depending on how you see things. More than that is there are a lot more structures there. And less than that because, well, it's a very, very narrow and small region. And that small region deserves some interest. So here's another cross-section, because once again, if you've seen what I've shown you previously, I showed you the very first cross-section I showed you. I'm going to go a little bit back, but this one, for instance, you don't see the transverse process at that level. So this is not where you would perform the block yet. You would perform it a little bit higher on the tip of the transverse process that can be seen here. And there you cannot see the posterior ramus. However, you will hope that by hitting that transverse process, your local anesthetic will go upwards and downwards and then block these different elements. If I zoom in a little bit, well, once again, I can see a spinal nerve emerging at the level of the intervertebral foramen, going out. And what we see here in that small region right there, well, is actually the posterior branch that is going downwards, and that will emerge in the small region that we could call the posterior paravertebral region. So if we look at what's happening, let's make it a little bit more simple. And let's draw two vertebrae, two thoracic vertebrae, and between those vertebrae, you know that there are ligaments, right? You don't want those vertebrae to go everywhere all at once. But those vertebrae also have connections to ribs, because in the thoracic region, ribs are connected and articulated to the vertebra. And in that region, we can find several ligaments. If I zoom in a little bit, well, you will see here the different ligaments of the region. So I don't think many of you have studied those ligaments when they were doing their anatomy courses, and I understand because there is not much literature on the subject, whether it be in ancient books or more recently. So the first ligament that we see is what we call the costolamellar ligament, between the lamina of the vertebrae and the rib. Probably not the most important ligament in this region, but we're going to come back to that. The second one is the lateral costotransverse ligament, that is between the transverse process and the rib. And you will also find a small muscle, that is the muscle that pulls on the lower rib to kind of make it go back up. That is the levator costae muscle. And last but not least, two very important ligaments. Those are maybe the most important ligaments of this region. The more anterior one is the superior costotransverse ligament. And this ligament you may have heard of if you perform paravertebral blocks, because it's often described for paravertebral blocks as well. And a little bit more posterior, but it's not there all the time, the intertransverse ligament. And as you can see, when you put all these things together, well, you will see that there are actually two spaces, two small spaces, one medial and one lateral. Those are highlighted by the red arrows that I showed you there. And why are these spaces important? Well, because that's, and we'll see it in a few seconds where we'll find the nerves. But let's continue focusing a little bit on ligaments. Because, of course, if we're different on the outside, we're also a little bit different on the inside. And you might know that there's a lot of anatomical variability, whether it be arteries, veins, nerves, etc. But there also is variability in terms of ligaments. And so sometimes there is an accessory band of the superior costotransverse ligament. And you see that the lateral space I previously showed is a bit narrower than what it used to be. And then I started thinking, okay, there is this variability, but how do you account for this variability? And so I went to the lab collections and started seeing some interesting stuff that I photographed and showed here for you. So this was meant for students to study the ligaments of the costovertebral region, right? And as you can see right here at that level, you see that there are two costolamellar ligaments. Not one, as I've shown you. And some might say that, oh, but on your drawing, you drew two ligaments as well, you just fused them together at the lower part. But yet, we will see that those small details probably account for a lot of the variability that there is in terms of blockade. Now, if we use the same elements and look at it from a lateral point of view, I zoomed in a little bit for you, then we can see that there are once again several ligaments. The intertransverse ligament, the most posterior one, the costolamellar ligament that accounts for less importance, I would say. And the most important one, most anterior one, the superior costotransverse ligament. And this might remind you of the way you put your probe. If you perform erector spinae plane block or paravertebral blocks, putting your probe sedatively and performing a puncture in plane, well, this is the kind of image you would see, and we'll talk about this a little bit later. So now that we've talked about ligaments, what about nerves? Well, this is the tricky part, because as I've shown you, the spinal nerve gives off first a posterior branch, and that same posterior branch will divide into two, a medial branch and right here a lateral branch. And so then we are stuck with this, the intercostal nerve that is anterior, and the posterior ramus of the spinal nerve that is posterior to these ligaments with two branches, a medial and a lateral one. And each of these will go through a different form. So if we go a little bit further and we try to put ourselves in the same conditions where we would perform the block and do first sagittal section at that level, well, what do we found? So in darker green, you can see that I highlighted the intertransverse ligament between two things, between two transverse processes. And in front of those transverse processes, we would find right there ribs. And from the upper transverse process to the lower rib, you would find here the superior costotransverse ligament. And if we cut that, well, we could actually see that depending on where you are at that point with the ligament, you will cut through at the lower part, the posterior ramus of the spinal nerve, whether at the anterior part you would find the intercostal nerve and vessels. If we go a little bit more laterally, well, there it is, the disappearance of the intertransverse ligament. So that is if you are in a sagittal section. If we look once again at sagittal sections for anatomy, what do we see? Well, I'm going to zoom in a little bit more to focus specifically on this very, very particular region. And once again, we see things happening. If you focus on one of those spaces, you can see that in front of the ribs right here, you would find intercostal nerves and intercostal vessels. But at the posterior part, you would find the posterior ramus of these same intercostal nerves. So if we look a little bit at a lower level, what will we find? Well, if we look at the lumbar level, it's a little bit different. There are no ribs there anymore. There are only muscles. And those muscles are, I must say, rather complex. They're very, very hard to dissect, even on fresh the bodies of donors. And they're very variable as well. So I highlighted the principles. The most common muscles, these are the interlaminar muscles, the intertransverse muscles, the interspinous muscles, and as you can see, the medial branch and the lateral branch once again don't go at the same time all the time. So this was very classic anatomy, I would say. This is anatomy you could find in the in most of textbooks. But there have been recent studies about that, and for me the most interesting recent study on this is a micro-CT study that was done by a Korean team in 2021 and published in Regional Anesthesia and Pain Medicine. And so this team, they selected several pieces of donors, and they micro-CT them. So the micro-CT is actually a very, very complicated technique that cannot be performed on patients. It can be performed on very, very small pieces of tissue or metal or anything you want, you name it. And it allows for a very high resolution because it can go up to 5 micron in terms of resolution. So you get those beautiful images. And what is interesting is that they described that previously the known concept was the one you see on the left side of your slide. And from their study, they had the exact same conclusion as older anatomists had, meaning they defined the superior costotransverse ligament, SCTL, the intertransverse ligament, ITL, and with those medial and lateral branches of the posterior ramus of the spinal nerve. And so once again, they are talking about two possible communications, either laterally to the superior costotransverse ligament that goes towards the paravertebral space, or medially to the superior costotransverse ligament that goes to the intervertebral foramen. And as I told you, they used micro-CT because these were only drawings that I showed you. And if you look at micro-CT from an anterior view, well, you would find two ribs right there. And more complicated, you would find the superior costotransverse ligament and then two openings, one medial, one lateral. And if we look at dissections that were performed on the microscope this time, and from a posterior view, well, once again, we see that there is a lateral branch and a medial branch of, let's say, posterior ramus of the spinal nerve. If we go a little bit more to probably the images you know, ultrasound images. Well, this is the view you want to have if you perform, for instance, paravertebral block. And you want to have this beautiful kind of image between two transverse processes, and you will actually see that there sometimes is that very thin hyperechoic line. That hyperechoic line is the one that was drawn in white right there between the transverse process and the rib. And as we've seen, if you're anterior to that hyperechoic line and anterior to the superior costotransverse ligament, well, you're in the paravertebral space. Whereas if you're posterior, you're not in the paravertebral space, you're a little bit further, and you will only block the posterior branch of the spinal nerve. These findings are consistent in everything they show. If you haven't read this paper, it's a very good paper. I think it explains quite a lot of things that we can have. There is a possibility of communication between what is posterior and what is anterior. However, what is not yet very well described in this paper is the amount of variability there is. The amount of variability there is at the level of T4, T5, where they're performing their CT scans, the micro-CT scans, but also at different type of levels. If you go one level below, if you go one level up, you will not find the same elements. And that is something that is important to consider, depending on where you will perform the block, you will not see the same things. And moreover, you have inter-individual, but also intra-individual, meaning right or left side variations. So what could the possible mechanism of the ESP block be? Well, that's where it gets interesting, because when you look at the literature on the effects of the erector spinae plane block, well, for some authors, it just allows for blockade of this posterior branch of the spinal nerve. Whereas for others, it also blocks not only the posterior branch, but also the whole intercostal nerve with the lateral cutaneous branch and the anterior cutaneous branch. So one of the main explanations that we have for the ESP block when it gives analgesia for the entire metamer is the fact that there is anterior diffusion. It is a paravertebral block by proxy. So if you haven't read this paper, the mechanism of actions of the erector spinae plane block, I suggest it because it's rather interesting. Why do I think this is not exactly the solution? Well, Because if diffusion occurs towards the paravertebral space or the intravertebral foramen, you would have a blockade of the entire metamer. You would have everything that is blocked, not only the posterior branch, but also the lateral and the anterior branch. However, when you perform clinical examination, there is very rarely a loss of sensation across the entire territory. And so some authors suggested that only C fibers are blocked. But once again, is it really the case? Another possible explanation is the fact that when you breathe, there is negative pressure coming from your pleura. And some authors suggest that there is kind of an aspiration of local anesthetic and that it goes from posterior to anterior. And that's why, for some, you would have the full effects of the block at 1 hour, 1.5 hours after you perform it. Other explanations. Well, could it be lateral diffusion? Could it be a retrograde serratus plane block? Well, actually it could, especially at the level of T4, T5. It could then block the posterior branch, but also the lateral cutaneous branch. Once again, not many studies, but if you look at how their diffusion is, if you recall the image I've shown you, the CT image of the erector spinae plane block being performed, and if you look at how the contrast diffused, well, you see that it is not only posterior, but it also goes laterally. And not always anteriorly. This is seldom, and when it goes anteriorly, you will probably see 1 or 2 levels at which it goes anteriorly, but not much more. Another possible explanation, a third explanation, is, well, we know that intravenous local anesthetic has effect as well. We've been using IV lidocaine for colorectal surgery, for instance. So could it be a systemic effect of the local anesthetics? That's also something to consider. Fourth, could it be an analgesic effect related to immunomodulation mediated by fascia innervation? Well, once again, not much data in the literature, but that was suggested in that paper. Since it was published 4 years ago now, there has not been much research regarding that. But one other possible explanation, and that's what I would like to highlight, is, well, are there not biases, methodological biases, in how we just perform the ESP block? And that's interesting, because I showed you there is extensive literature. But remember when I said that to perform an ESP, you had to, well, go with your needle to the tip of the transverse process? Well, this is an image I've taken from a randomized control study that is showing how they perform erector spinae plane blocks. Well, the red arrow here highlights the transverse process. Yet you can see that the needle is nowhere near the tip, the transverse process. It goes deeper. The green arrow highlights the exothoracic fascia. Well, we're below that exothoracic fascia, but look at the needle right there. Where does it end? Well, I don't know where it ends. And this for me is a major issue, because when we perform blocks, we want to perform them and make sure that the localization of our needle tip is precise, so that when we inject our product, we know where we're injecting it, reducing the risks, but also adding, having a better success rate. And as I've shown you, the anatomical region of interest is very, very small. So just 1 millimeter of your needle going in one direction or the other could actually change a little bit the outcomes. If you have any questions, I'm available. I know it was a rather dense lecture. I hope you weren't too bored. And yeah, I'll answer any questions you have.